So just to begin, we've got an excellent lineup tonight. I think I'll just start introducing in a minute, but just a reminder that we will have some question time after all of the speakers have finished speaking. So our first two speakers are Amy Burkett, who is a clinical psychologist currently working as the Clinical Services Manager at QPASTT, and Dr. Rebecca Farley, who is the GP Clinical Lead for the Brisbane North PHN and also one of the GPs at the Mater Refugee Complex Care Clinic. So if you could welcome them.
Thank you, Rachel. Tonight we'd like to just basically talk about how trauma presents in primary care and how it impacts on our ability to care for our patients from a refugee-like background. And when Amy and Fernanda first asked me to be involved in this evening, they asked me to have a little bit of a think about my experience working in general practice and how trauma impacts on my care of my patients. And I guess one of the key thoughts that came to my mind was really that when I'm seeing patients, I guess I just assume that most, if not all, of my patients have probably experienced some form of trauma in their journey to Australia. And in many ways that's enough to inform my practice. So certainly when we see patients who have newly arrived in Australia, we encourage you to do an assessment for emotional wellbeing and mental health, and that should certainly be part of that post-arrival health screening. But it's important to remember that concerns in these areas will often only present over time as we develop that trust and rapport with our patients. So generally, it's not advisable to in those kind of early consultations explicitly ask patients about their history of torture or trauma, but it's something that should really be there in the back of your mind as you're working with patients, that this might be something that's going to be impacting on your relationship with them and their ability to access healthcare here in Australia. So this was a slide put together by Amy. Really just to show, I guess, those layers of complexity when we're seeing a patient from a refugee-like background. So we all have those common kind of life experiences. Any patient that we see will kind of bring all of this stuff that's going on outside of our consultation rooms. But for people from refugees and asylum seekers, there's these added layers of, that whole journey, perhaps conflict or persecution that they've experienced in their home country, the experience of fleeing, perhaps being in a refugee camp or detention centre, and then coming to be in Australia and settling in Australia, and all of those experiences just kind of add greater and greater complexity, and they're kind of inextricably linked to and impact on that patient's experience of their day-to-day life and how they work with us to manage their health. So whenever I see a patient, there's all these things kind of running through the back of my mind, and certainly the possibility that this patient has experienced trauma is in the back of my mind. But this is a picture that I often include when I'm speaking about this. It's a picture from a hospital in Dili in East Timor, Timor-Leste, where I was working just after I graduated. And it just, I think for me, it was a really key moment in my learning, I guess. This hospital was really well resourced at the time that I was working there. But there was really only ever one or two patients in the hospital. And on the same day, just down the road, there was this other clinic that we were working in that was really just kind of a couple of buildings. There was this kind of dirt quadrangle. It was really poorly resourced. There was one doctor working there. And so many patients would just wait out in the hot sun to see this doctor. And, over the time that I was there, the story kind of gradually emerged that really the hospital during the Indonesian occupation had people had experienced torture, people had been killed in the hospital, and so, over a decade later, even though people kind of knew that it was safe, they just weren't going to go there. And I actually have spoken to people who've been there far more recently, and they say that the situation's still much the same. And so I think whenever I see a patient for the first time, when they've just arrived in Australia, I just kind of remember that. Coming to see us can be such an anxiety-provoking experience. Healthcare providers are not necessarily these trustworthy people. Sometimes, they've been linked to some terrible things, and just coming into a clinic setting, that physical environment can be really distressing. And when we're talking about mental health, again, that can just be such a foreign concept for many of our patients. They've never heard of this kind of idea. And then we add in, the complexity of having multiple family members. We're trying to work through interpreters, and you can just see how difficult this can be. So while we don't encourage you to start asking in great detail about someone's history of torture or trauma during those initial consultations, we do encourage you to do a health assessment. And as part of that, you will be asking these sorts of questions, asking about migration history, asking, when did you leave your country? What was the situation that led you to leave? And, who is in your family here in Australia? Who's in your family back home? And I think as we start to ask those questions, we start to get a little bit of a sense of people's experience and the trauma that they might have been through. And we ask about these kind of questions around current functioning, appetite, daily activities, how they're sleeping. And again, we start to get a bit of a sense for how things might be impacting on them now. And I find sometimes during those initial consultations, people will disclose a history of trauma to you, and they might want to talk about it, but many won't. And I think you really just need to be prepared either way for that. Over time, I think we do start to see more of the symptoms and signs that might suggest that people are being impacted upon by their experience of trauma. And, we do, I think, as we've developed that bit more of a close relationship with our patients over time, we see people presenting with mental health symptoms around mood, sleep disturbance. Sometimes we see those really complex chronic pain syndromes that we really struggle to tease out. And, issues around memory and concentration, often we see it just in people not, just trying to get to appointments and that kind of thing, struggling to get to TAFE classes. We start to kind of see all of these things, present. So I'm just going to hand over to Amy now, who's going to have a bit more of a talk about how trauma impacts on people and what we should be watching out for.
So I guess, as you can see, there's a long list of things there. And I guess the point of that is to think about trauma impacts people in many different ways. So it might impact someone directly, it might impact someone indirectly. This is sort of a really kind of brief overview of some of those things. And for children, for young people, for adults, you might see different things as well. But, for example, someone might develop that expectation that bad things are going to happen to them. That's been something that's recurred over and over, and so that might be a common theme that comes up. Have difficulty forming relationships with other people. That might have been something that's always been abused for them, or has always been sort of, a source of that persecution, and that can come through as well. Difficulty developing a positive sense of selves. Trauma's remembered in the body, as we kind of go through it a little bit more in terms of those ways that you might see that coming through in your patients. Identity formation and sense of self, by definition, a refugee is someone who might have been persecuted against something that's specifically related to their identity. So what that then can cause and the impact that can have. And often the brain's in survival mode. If you've come out of those experiences, then that might still be the state that you're in. And I guess, when you think about, or when we talk about these, it links with what Rebecca's saying as well, is having these things in the back of your mind. And it might just be some of these things that come up that ordinarily you wouldn't think, I might link that with trauma, but it's useful to keep that in mind. Again, then linking some of these things, that these might be direct things that you come across, and direct kind of things that someone might be talking to you about, or things that you might notice, when you're consulting with someone. So I'm not actually going to go through all of them because there's lots of different things there, and this is really just a snapshot of what you might see, but you might be sitting there going, yes, I've had a few people who've presented like this, and again, it's getting you thinking about, I'll keep these in the back of my mind if I'm starting to notice some of these things as well. Do you want to take that over?
So for me, I think then when it comes to asking these kind of more specific, detailed questions, that often comes when I've really got that rapport with my patients, and I guess I might be starting to see some of the things that Amy's mentioning. And I guess when we ask these sorts of questions, it's just so important to consider the potential for triggering a trauma response, and so just making sure that you have the time and the space and the relationship with the patient to really be asking these questions. And these are just some examples. These actually come out of the ACID guidelines if you want to go and have a look at some really concrete examples of how to ask these things that are quite difficult. So just talking about how terrible things have often happened to people who have been forced to leave their countries, saying, I don't need to know all the details if you don't want to talk about them, but about what you've been through, but is there anything that has happened that might be affecting your health now? I think the other thing that I often find quite useful is just to sort of normalise what people might be experiencing. So I know often patients can be really distressed by the difficulty that they're having sleeping or the nightmares, and that in itself is actually really distressing. They're worried that means something terrible is going on. And sometimes just being able to say that, that I work with a lot of people who have perhaps been through journeys like yours, and this is a really, really common response to having gone through something so terrible. I find can be really helpful. Is there anything you want to add to that?
The only other thing that I guess comes up for me when thinking about this, and it probably sounds really simple as well, is using the client's language. So, often kind of if something might come up, I have this sadness or I have this pain or whatever it is sort of using their language to try and explore that. When you have had this sadness, what does that mean? Or other people that I've worked with, when they've described something similar, it might mean this as well. So it's sort of, also linking in some of those other experiences that you have, but also making that connection to their personal experience.
So again, having ensured that you're really in that space, responding to that disclosure, I think can again be really challenging. And I think it's just about acknowledging the person's experience and the associated pain and being willing to sort of sit in that space with them. Remind the person that their reaction is characteristic and in many ways a normal response to what they've been through. Avoiding false assurances, but also allowing them to know that there is support available. And again, just expecting that there's going to be inconsistencies, and that while the patient may be willing to talk about this today, they may not be willing to talk about it again. Because I think, again, often it's just a moment in time where the situation is appropriate that we hear about some of these things. Again, anything you want to add?
Yeah, sorry. I might just add there as well, something that I guess comes up is thinking about that containment as well. So if you're sort of, with someone and they start to disclose something, and sometimes that might lead to someone increasing, in their levels of distress, or they're worried or they're tearful, is thinking about kind of, is there something I can do to just sort of, pull it back in for them and help them contain that, so that when they walk out of the room, they're feeling okay and they're feeling safe again. And sometimes that can be as simple as, as Rebecca said, validating that experience, normalising that. They've had that space to talk about that, talking about referrals, which we're going to go into a moment. Sometimes that can just help to make someone feel a bit safe again as well. So just keeping that in mind as well.
Thanks, Amy. I think that's something that I sometimes really do struggle with. An hour later, I'm still sort of trying to find a way to contain. So then in terms of referral, this I think can be quite a challenging area, and we're going to come to talking about the mental health pathway tool later on in the evening, which is a wonderful tool to help us navigate this. But basically, if the patient's mental health issues are related to torture and trauma, they should be referred to a specialised torture and trauma service. If there is no torture or trauma history, then perhaps other mainstream mental health services may be more appropriate. And you just need to really, I think, in terms of the services that are available, we will talk about this later, you just need to be thinking about what you actually want from the referral, what is the acuity of the issue, and I guess, is this related to trauma, or is this perhaps more, anxiety or depression that we, related to the situation here in Australia now. In terms of discussing referrals, again, I think this can be a really challenging area, but just explaining the purpose of counselling in simple terms and in ways that normalise and destigmatise mental health. So again, just saying, many people who have experienced terrible things have worries, fears, experiences, things like the things you're experiencing, nightmares, difficulty sleeping, that sometimes don't go away by themselves. And I often don't even use the word counsellors. Often I'll just say, that there are people in Australia who have a lot of experience, working with people who are feeling like you do, and often perhaps speaking about things can help them to deal with them a little bit better. So just gentle, again, using the language, I think, of the patient, kind of finding where they're at and meeting them is really important. And I think it's, again, just knowing that counselling involves engagement. And so if the person doesn't want a referral, that's absolutely fine. And just, I think it's important to kind of show your acceptance of that and just making it clear that opportunity for a referral down the track will be there. And again, I'm amazed really how often, in really just 2 or 3 consultations, someone might come back to me and say, those people that you were talking about, maybe it might help me a little bit to maybe talk to someone. I was speaking to Amy about, those patients that really are quite resistant to any kind of referral, and she had some lovely ideas around strategies perhaps to talk about mental health services. So I'm going to hand over to Amy to talk a little bit about that, but also just to talk about what QPASTT does, the referral process, how they work with our patients, and also how we can kind of work collaboratively once that referral's been made. If we have time, which we may not, she's just going to touch briefly on vicarious trauma and burnout as well.
Lovely. Go back. No, that's okay. So I guess one thing when we were sort of talking and preparing for this, it came up around that concept of which comes up very often is when we bring up, say, trauma counselling or talking to someone about your past or trauma, there can often be that real sort of reaction of, I don't want to talk about my past. I don't want to think about that. Every time I think about that, it makes me worse. And I guess sort of what came to mind is, the way I might often sort of describe trauma counselling to someone is by using that sort of example of driving a car. And you think about, regardless of someone's experience, everyone generally can, appreciate what it means to drive a car or be in that. And so I'd explain that you as the client being here, you're the driver, you're driving this, you're in control. I'm going to sit in the passenger seat and I'm going to be with you the whole time. And our aim together is to move forward. And that's where we kind of want to go. We want to move forward. Sometimes there's going to be things that are unexpected and come out of the way, and we can deal with those together. And sometimes as well, while we're moving forward, we're actually going to have to look in our rear view mirror and look backwards, because sometimes we need to look back to be able to keep moving forward. And it sort of is a way of kind of describing that sometimes it is actually going to be necessary to talk about some of that trauma that you've been through, but we're not going to dwell there. The aim is to help you heal and to help you recover. And so briefly, I guess, is sort of talking about, in terms of then what would that mean if you're seeing someone and they've agreed and they've then sort of, made a referral to us, to QPASTT. So I guess sort of, very briefly, what's needed on a referral. The more that you can include is going to be beneficial for us, because I guess what that's going to help us with is, which team do they go to? Is it children? Is it family work that they're needing? Is it adult work that they need? Is it groups? Are they not ready for counselling, but they'd actually like to engage in sort of a social group or something like that? And so once we get that, we triage that in terms of, priority, and that'd then sort of, find its way onto a wait list in terms of the appropriate team. If there's something, if we need more information, we're going to get in touch. We're going to sort of find out a bit more. Often we get really complex referrals and there's some information that's really unclear, or the client's in a heightened level of distress. So we might see them really, within a few weeks and make an assessment and sort of support them in that sense. I guess there's lots of different, services that are available within QPASTT, and once we engage with someone, they might get linked in with lots of different things as well. And I guess sort of, for us, what's really useful and for our clinicians is being able to have that collaborative relationship with the GP or with with whoever the referrer is. You often have, a point of contact with the client that might happen at different periods of time and are supporting them in different ways. So being able to collaborate is really useful, and we really welcome that relationship as well. Okay, we're getting the wrap up. So I guess, in my last 2 minutes, I will touch on vicarious trauma and burnout. It needs a lot longer time. A day at least. So I guess it's if one thing you can kind of take away is that understanding that when we work with people with complex trauma and within this field, at some point you're likely to potentially experience these kinds of things. Clients are very good at hitching a ride home with us, very good at making their way into us. And so it's about sort of recognising that as one of the first steps, normalising it, that it's okay, we all go through these sorts of things. And I'm just going to really quickly skip through some of this. But I guess there's sort of, again, a whole list of different things that sort of strategies that might be useful and you find useful. But there's another really simple debriefing technique, and you might look at it and go, that's too simple, it wouldn't work. But it's about creating a little bit of distance. You can do this between patients, you could do it at the end of the day, and it's just taking a few minutes to kind of, centre, ground yourself and create some space. Who am I? How am I different to my client? What are some things I can't change? Because often that can cause a lot of stuckness for us. What are some things that I like about myself? How can I, create that space as well? And tuning into, how's my posture? Have I taken on the posture, that heaviness of that client that I've just been with, and kind of undo some of that before I step away into sort of leaving here and leave that day behind. So I know that's very, very brief, but that might have got the point across, yeah.
I was just going to say, I heard Fernanda say that years ago, and I remember thinking it's too simple, but it makes a big difference, and I use it. I still use it. Yeah. Thank you.
Thanks.